And so it's my pleasure to invite Professor Michael Blaivas. He's a professor of medicine, part of the board of the Ultrasound Institute of the University of South Carolina School of Medicine. He's also an expert in point of care, as having worked and being board certified in emergency medicine, and he's also president of the Society of Ultrasound in Medical Education. So for sure he's perfectly suited to discuss the topic, both related to the disease we are discussing today and to the education of physicians in these modality topics. And so this also could be a matter of discussion at the end, and I would be pleased to put some questions. Please, Michael.
Thank you very much for that kind introduction, Fabio. Hopefully everyone can see my screen and can hear me. This will be a little bit of a lighthearted discussion, but have some key educational points where I think a lot of errors can potentially occur, and errors that simply confuse providers, clinicians, others in terms of what they can get out of ultrasound and caring for their patients, especially in the time of COVID. The title of my talk is The Sound of Water, B-line Artifacts. I cannot advance. Here we go. I do have some disclosures. I won't be talking about any of these companies' products. And we have several objectives, describe B-lines and lung ultrasound, talk about some of their nuances, how machine settings can influence B-lines. It's an old topic, but it's often forgotten. I frequently see people scanning in cardiac presets or others, and we'll talk a little bit about what happens. And then discuss some evidence regarding B-line identity and future directions. If we go back to the consensus document that we did in 2010, actually, in the Bologna Sheraton Hotel at the airport, and that was the big meeting, and then published in 2012. If you dig through, B-lines are discussed as originating from the visceral pleura. The normal pleural line is very thin, and B-lines are laser-like projections that go straight down. They're not supposed to widen, they're not supposed to disappear. And all of these things, I think, are important, but difficult to keep in mind for many people. And our views of B-lines are not really optimal, I think. There's some dirty little secrets about B-lines, and I think to many of us, they all look alike. And this is almost like B-line racism. And we'll use Martians, the classic descriptions and the historical knowledge we have about Martians to use as a corollary. In fact, B-lines don't all look alike, and we've discovered that Martians don't all look alike. It's just most of us don't notice. When we look at Martians, they're described as little green people, but in fact, we know from historical depictions over the years, as shown here in actual photographs, that Martians don't all look alike. Some of them have larger eyes than others. Some of them look very human. Others have different facial features, different size craniums. So probably this goes back to where on Mars they grew up or evolved different conditions forcing different pressures. The same thing happens actually with water, the sound of water, the title of my talk. It turns out not all water sounds the same. Hopefully you can hear that in the background, but depending on what the water is doing, where the water originates from, or where its movement originates from, will impact how water sounds. Thus, another corollary for us that maybe not all B-lines are alike. In fact, are they all B-lines or not? I think this is a valid question, and COVID has really brought this to the forefront. Here are some examples of what could be B-lines or typically described as B-lines. You have different types of transducers, curvilinear, phased arrays, lung settings, non-lung settings. You have one of the more original, a microconvex array, which is what historically lung ultrasound was really born with. You have a linear array and others. So let's take a look at some of these. Here's a very nice curvilinear array. You can see beautiful B lines here, individual ones. Others that are a little bit less clear, are they really B lines? Some thin pleura, maybe some disruption. So this is a very nice depiction of B lines and thin pleura. Now let's take a look at this linear array. You have pleura here. Clearly it's a little thicker in some areas than maybe others. Are these all B lines? Do they all originate the same way? It's not a great quality image, but it gets you thinking that maybe there's more to this than our view of Martians, that they're all the same. Here's another one. This actually is from a congestive heart failure patient that happens to have acquired COVID as well, that I saw some months ago. You have B lines, you have maybe something a little bit different because the pleural line suddenly takes a step here. It's irregular. It's thin here, becomes much thicker. The B line also has this unusual appearance, so some things to keep in mind. Maybe they're not all the same. Here's another image of a potential B lines. We have the pleural line here, but look how prominent these B lines are. Are they B lines? Is there some thickening of the pleura here? What's happening in this area as well? So there are probably some questions that are worth asking. There's a good reason, a good historical reason that I think some of this confusion arises. The origins of lung ultrasound, I personally think, really date back to one institution, one person, and the use of a 1984 Hitachi machine with a curvilinear transducer. It's depicted here. This is one of the higher resolution and prettier images I've seen. And note how we can see the pleural line. There's not a lot of definition. Clearly, some beautiful B lines. We can't say too much about their origin. And this limits our ability to say much about differences in pleural line, thickening, disruption. And I think that limited the field in a way. That's fine, but now ultrasound technology has progressed significantly since 1984. And I think that's actually one of the reasons we saw and have inherited this frequent use of M mode, because there was not a good capability to depict what was happening at the pleural line. So M mode was used as a crutch that I think is not needed quite as much anymore as it used to be. Now, here's an interesting thing when it relates to COVID patients. Obviously, this is probably not news to most, but it's a good reminder. The fact that so many lung lesions are peripheral in nature, and this is actually very important for using lung ultrasound, because as you recall, if the lesion does not reach the periphery of the lung, just as in the parenchyma, then lung ultrasound won't see it. Most early studies and every study that I know of since documented the peripheral nature of the lesions. These are earlier ones, a patient that has very few symptoms, and obviously this can involve much more significant symptomatology. But notice the consistent peripheral nature of these lesions in COVID-19. Now, this is why I think paying attention to B lines is so important. And many people have discussed B lines before. There have been great controversies regarding what truly generates a B line, what does not, what is the origin of these incredible artifacts, but not as much attention has been paid to how you can alter them. There is literature discussing the fact that tissue harmonics eliminates B lines. I know I first noted this in 2004 in a study we did, and it was a very interesting experience to realize that some patients, in fact, would be described as having no evidence of pulmonary edema when tissue harmonics was turned on, and a modern probe at that time was used. But when you used a more rudimentary probe, they clearly had pulmonary edema. I think few people have studied this as well as Dr. Kameda from Japan, and this study maybe does not get quite enough attention, but I am a big fan of it. And he and his team took a look at a number of factors, such as adjusting focal zone. Most ultrasound videos and images that I review have the focal zone set lower. And in fact, some companies automatically in their lung presets set the lung zone lower. But look at what happens when the lung focal zone, or the focal zone for the image, is set too low. It widens the B line, and in fact can create false B lines potentially, especially when you have a multifocal imaging. Now, please note that the frequency of the imager has impact on the B line as well, such as even potentially eliminating it when you go from 8 to 11 megahertz. And then here's that effect of tissue harmonics, eliminating B lines completely. And most of us, I believe, forget this. I no longer do, but used to for years. So we really need to eliminate post-processing, or we impact the appearance of our B lines. Now, why would we set our focal zone at the pleural line? Because if we read the consensus document from 2012 and others, ultrasound does not really image below the pleural line in most cases unless there's significant parenchymal involvement, and Christoph showed some great examples of this. Thus, if we're really imaging to the pleural line and everything else is artifact, we should have our focal zone at the pleural line. And here's an example of what happens when we don't. I've seen this be a confusion in incredible places in the United States, in the top marquee ivory tower institutions. It turns out that no one understands how to do lung ultrasound personally, or in actuality, and I've personally gotten to witness this, and I've been shocked. And it's these little details that escape people. There are other factors that influence B lines. Here is a very nice depiction of some of the things that can influence B lines. Here's another one looking at focal zone and how it can distort the B lines, widening them. And remember, the classic description of a B line is a laser-like projection, more like this, not something like we're seeing here. So you can completely alter the appearance of B lines depending on the frequency you're using, adding tissue harmonics, and where you place your focal zone. Obviously, angle is a crucial factor for B lines. Being off angle a little bit, you can widen your B line, as Dr. Kameda shows here. I've actually more experienced that you lose B lines. The handheld imager that I've scanned the last maybe almost 150 COVID patients that I've seen in just less than 11 months, I find that when my angle of incidence is not perpendicular exactly, I can miss B lines, but I tend to catch the artifacts that COVID creates much better. And where this is a problem is when I have a combination of congestive heart failure or pulmonary edema and the possibility of COVID. Here's another last look at frequencies and how change in frequency can impact what size B line you can detect. Remember, if it's some sort of a defect at the pleura, or increased fluid content at the pleura, depending on the frequency you use, you may or may not be able to detect a very small B line or artifact. And a ubiquitous complaint that I see in the literature, have heard in forums, webinars, elsewhere, is that I, as the clinician, can't tell apart COVID lungs from congestive heart failure lungs. Now, interestingly, while I may have started seeing COVID patients only in March, given my location geographically, I work with a population that's extremely sick, extremely unhealthy. Almost everybody seems to have congestive heart failure, thus pulmonary edema, emphysema, or COPD, and then they started coming in with the possibility of COVID. And early on, I was faced with a 9-day turnaround for my COVID test. How do I risk stratify these patients? And the answer is pay attention to the B lines, the origins of the B lines, and keep an eye on the pleura. This has been discussed fairly well, but I want to reiterate just how important it is. If need be, magnify the image, decrease the depth, get a better look at the pleura, or possibly use a second probe. If your phased array doesn't show it well enough, as some don't, possibly add a linear, or if your phased array does show the pleura fairly well in the near field, as I was fortunate to have with the scanner that I was using for all of my COVID patients, or most of them, I could magnify that area, the near field, fairly well. But a good compromise might be a curvilinear transducer, especially a high quality one, which can show the near field well. And here's an example. So this is actually a patient I saw about 3 or 4 days ago now, but this is a 73-year-old male, status post heart transplant, presents with dyspnea, hypoxia. I'm waiting on a COVID test. Chest x-ray is read as nonspecific by radiology. Because of the pressures radiologists are under in the States, almost every chest x-ray is now, for me, read out as consider possible COVID-19 infection, get other testing. So chest x-rays interpretations have become completely unhelpful in the clinical setting. But if we look at the lung ultrasound closely here, we see the pleura. It's fairly well depicted, B lines, but we see different types of B lines. Notice this one originated from thickened, disrupted pleura. Some others originate from nice, thin, clear pleura. And these are a combination of B lines and something else. These other B lines, some have argued in the literature that they should go back to calling these comet tails, but clearly there's something else going on, even a subpleural consolidation. And this is a case where you had coexisting pulmonary edema and COVID. The test eventually came back positive. So here is a look. Now the depth has been changed to 6 centimeters. This phased array manages to image the near field fairly well. Some do it better, probably, some do it worse. But we can see just how the pleura appears here. Very disrupted and normal here, disrupted here. Hopefully you're able to catch this via the webinar transmission. But if you watch the pleura carefully as the video plays, you have some abnormal pleura and the B-line-like artifacts generated from it. That's from COVID. And then elsewhere, more classic B lines, that's from the pulmonary edema. So I found out early on, middle of last March, that I could differentiate this in my patients, and much better than chest x-ray, and definitely better than the COVID tests, which at that time for us were about 9 days for turnaround. What really clears this up is a great study using artificial intelligence. This has been a huge interest for me over the last 5 years. I have been focusing research and publications with partners worldwide on AI. And this is a great one with Dr. Arnfelt from Canada. He and I have partnered on a number of projects. And what he did is took a look at hydrostatic pulmonary edema, non-COVID ARDS, and COVID findings, which he termed COVID-19 ARDS, in his ICU. Clearly, these are 3 things that could potentially confuse sonologists, and he did a AI project where he trained an algorithm and compared it to expert human reviewers. And interestingly, the AI blew humans out of the water, an AUC of 0.79 for humans compared to 0.98 for the AI. And this is very significant. But the most compelling part is what happened when he used a technique called heat mapping. And what heat mapping is assigning a color to pixels of different values in relationship to how important that pixel was to getting the right answer for the AI. Thus, anything that's really bright and glowing, let's say like this blue, was most important to the AI getting the right answer. And remember, the AI classified pulmonary edema, ARDS versus COVID extremely accurately. And it turns out everything that was important was really up in the pleura, in the near field right here. The B lines themselves were hardly of any value. Thus, the pleura, the origin of any B lines, is where the gold is at, where the answer is at. That's how you get the correct diagnosis. And I think this really seals the answer to this case. In summary, first I'd like to thank the organizers for inviting me. I'd like to thank all of you for listening. The sound of water, I think, is quite deceptive. B lines, as used by most of us, are not all alike, and this creates tremendous confusion that, again, as I have mentioned, I've seen at the best medical centers, academic medical centers in the United States. Obviously, I think lung ultrasound is done in other parts of the world in a better way. Not looking at the origin of B lines will lead to diagnostic failure and confusion, as I've mentioned. So please don't ignore the pleura and don't fear sorting through B line details for the benefit of your patients and your own practice. Thank you very much.